Hello, good evening. Well, it is a great pleasure to be here with you. My name is Evanios. I am an oncologist here at Curitiba in the Institute of Oncology of Paraná, and I will be here continuing with another Pfizer Lung Cancer Connect, and we will be discussing exactly one more perspective about lung cancer. And then we know that lung cancer has had great advancements here, and we can observe the lung cancer as orphan diseases. Every day we start to prepare with new biomarkers. We don't think that we have seen a disease that has advanced so much with the biomarkers and the recognition of biomarkers, whether they're diagnostic, agnostic or non-agnostic. And really this has brought a great challenge for us because from the standpoint, therapeutic standpoint, not only because it's the update that has to be very quick and very constant, and because the incorporation of medication is very good. We have several options and we have different profiles of toxicity and we have diagnostics. So sometimes the level of materials here today is not sufficient for the amount of exams that we have to do.
And therefore, we also have all these aspects that we have to discuss. So I think it's not an issue just for us. Actually, it's probably for everyone. I mean, this diagnostic definition is very complicated. Sometimes we're talking about a very quick treatment, and we also have to accelerate the diagnosis process so that we can discuss how we're going to use these platforms. Actually, these platforms, they're not necessarily similar, so we're going to have to see this material from different sources, biologic sources, so that we can reach the best diagnosis and we can offer the best treatment to our patients. So in this scenario, I am here on behalf of Pfizer, Actually, this is my disclosure, actually, as a guest here. And we will have an international speaker, well-known speaker, Dr. Todd Bauer. He is an oncologist, a senior investigator from Sarah Cannon Research Institute, and he will be talking about an update about this different scenario, this treatment landscape that we have for ALK positive carcinoma. So we have different and very specific therapies, and probably it's one of the diseases with the really the highest number of molecules that we have nowadays for lung cancer. That's going to be an interesting discussion, and we'll also have a case, so that's going to illustrate everything. Well, I wanted to thank everyone once again, and we will turn it over to Dr. Todd Bauer now. So, Dr. Bauer, you may begin.
Thank you very much. I appreciate the chance to be with everyone tonight. I know it's about 8 o'clock there this evening, and I appreciate you spending your evening here with us. What we want to talk about tonight is the evolving treatment landscape in ALK-positive non-small cell lung cancer. And we're going to look at some recently approved agents and how we can sequence those. We have what I refer to in the ALK-positive world an embarrassment of riches. We have a ton of options for what amounts to actually a very small population of patients. So I want to think about how I consider those options and how I would recommend that you guys start to think through the best way to sequence these. We want to look at I'm going to present just one quick case of lorlatinib in the first line. And then I do want to speak to some of the side effects of lorlatinib because it is a newer drug with different side effects. When I say newer drug, what I mean is it is a third generation ALK inhibitor. We have crizotinib, which is a first generation. The second generations include ceritinib, alectinib, and brigatinib, and incertinib. And then lorlatinib stands alone in the third, is a third generation drug. It is a macrocyclic molecule, so a different structure than the other ALK inhibitors, which provides it some different properties, but also some unique side effects that we're going to address this evening. So if you think back to the approval of crizotinib in August 26 of 2011 here in the United States, that was the first approval for an ALK targeted agent. If anybody could name for me the actual publication when EML4 ALK was shown to be a driver alteration, that was only 4 years and 2 weeks ahead on August 7th, 2007. So in just 4 years, we're able to get a drug approved for this small population of patients. But then look at the next 10 years. We had full approval of crizotinib, the approval of ceritinib, then brigatinib, then alectinib, then brigatinib, then lorlatinib. And now we have first line approvals for these drugs as well. Incertinib is sitting out there with its EXALT data, which we expect will get approval as well in the United States. So we've gone from a population of patients that's 3 to 5% of all the lung cancer patients out there. And now we have 5 drugs for them, which is a great problem to have. How do I choose? Well, if I have to choose, there are 2 ways to think about it. One, we can think about the basic science of it, which is this best drug out there. And then 2, we can think about the clinical application. How does it really play out in the clinical world? Well, we know that not all ALK fusions are alike. In fact, there are at least 8 different variants of ALK, and it has to do with where EML4 and ALK actually fuse and make that fusion protein. Because they aren't all the same, we need to decide which ones are most important. Well, we see that EML ALK version 3A and B and EML4 ALK version 1 are the most common, accounting for probably 65 to 70% of all those ALK fusion proteins. Well, if we know that, can we then try and figure out which is the best drug for those? Because that's going to be the best drug for most patients. This is what we refer to as a heat map or a stoplight chart. For myself, who is red-green colorblind, I think it's a cruel joke, but I can still read it because I put these numbers in here. If we look on figure A, this is EML4 ALK variant 1. The bigger the number, the higher the IC50. And remember, the lower the IC50, the more potent a drug is against that particular target. So for wild type variant 1, crizotinib comes in at IC50 of 23.3. As you slide left to right across that, you see that lorlatinib is 2 log-fold smaller at 0.267. Brigatinib comes close at 0.959. We look at ALK variant 3, same pattern, crizotinib at 205, lorlatinib at 4.5. So again, 2 log-fold smaller. Now, this is important because that suggests that lorlatinib is the most potent molecule against the most common ALK variants. The other thing I'll draw your attention to as you go down the left side, these are the resistance mutations that we see occur upon treatment with other ALK inhibitors. The G1202R mutation being the most prolific, hard to treat mutation in both variant 1 and 3. We still see that lorlatinib maintains good IC50 levels against those resistance mutations, whether it be in ALK variant 3 or 1. This is a better chart for me to look at. And again, these are from Ignatius Su, who I greatly appreciate sharing them. This is a bar chart simply showing these across the board. And you can see how profound that is when you look at it in this fashion. 23 and IC50 of 23.3 versus 0.267. It's almost non-existent at that level, which is a good thing in this case. When you look at that ALK variant 3, 205 versus just 4.5. So really a dramatic difference in how potent the drugs are at this. Now, the question that I come back to always, and I follow sports a lot, is how do you want to sequence your drugs? Because in my mind, it's all about what's the best way to take care of that patient. Is it putting them on the best drug up front or sequencing them front to back? So I use a lot of sports analogies as well. The question is, do you start Pele and try and win the game up front? Or do you keep Pele on the bench and put him in the second half when you start to lose the game? It's really just a mindset thing, a discussion with your patient. So these are the first line trials against crizotinib. We have the oldest study out there, the ALEX study looking at alectinib versus crizotinib, ALTA-1L, which was brigatinib versus criz. We have ensartinib versus criz, and then lorlatinib versus criz on the CROWN study. These studies are all roughly similar, about 300 patients. The first place we see them separate is in that objective response. All of the second and third generation ALK inhibitors do indeed beat crizotinib. Alectinib, it's important to note that this first data cut for alectinib, where you see 83% response rate versus 76% response rate, those were investigator assessed. The other three studies, that first one was by a blinded independent review committee. So alectinib's at 83 versus 76. Then you see brigatinib at 74 versus 62, ensartinib 74 versus 67, and lorlatinib 76 versus 58. So clearly the second and third generation drugs beat in response rate to crizotinib. Well, how about in progression-free survival? Can we see a difference in there? Well, if you look at alectinib, brigatinib, and ensartinib, the second generation ALK inhibitors, they all have a hazard ratio for PFS of about 0.5, and it is roughly 2 years, maybe a little bit more, versus just under a year. So 26 versus 10, 24 versus 11, and 26 versus 13. So those look pretty similar in their separation. When we come down to lorlatinib on the CROWN study, you see a hazard ratio that is significantly different at 0.28. And that is a median PFS for crizotinib at 9.3 months, so a shorter PFS versus not yet reached for lorlatinib. Now, this is where I need to pause and remind you that this is cross-trial comparison, the thing we're told never to do, but we all do all the time because that's the world we have to live in. So these are not statistically founded comparisons, but it's the best we're able to do. Look at these top-line results. So what's a big problem in ALK-positive lung cancer? Well, we know it's brain involvement. So we need to see how well these drugs work in the brain. Clearly, the second and third generation ALK inhibitors work better in the brain than crizotinib. Where again, you see for alectinib an 81% objective response rate versus 50. Now, this is interesting. Again, these were investigator assessed. When you get down to the blinded independent review committees for crizotinib, that intracranial objective response falls to 20 to 26%. So much smaller percentages. Yet the intracranial response rates for brigatinib, ensartinib, and lorlatinib all are significantly higher, 64 to 82%. So all of these drugs work better in the brain than does crizotinib. Now, can we tell a difference between the second and third generation drugs? Well, if we look at the CNS response rate, I believe we can. This is the CNS complete response rate, where alectinib had a 38% complete response, investigator assessed, versus 11 for brigatinib versus 27 for ensartinib. But again, in a blinded independent review, 71% complete response to lorlatinib. So again, I think this is where we start to see a separation where the second and third generation drugs are clearly better than the first generation drug crizotinib in treating to objective response and in the brain, but that complete response in the brain is best with the third generation drug, lorlatinib. This is a great slide that Christine Lovely put together, and I appreciate her sharing it with me. She presented at ESMO last fall. The take home from this is that as we look at the later data cuts, specifically in the ALEX study, even out to 37.8 months, that PFS maintains significant benefit, actually gets a little bit better with a hazard ratio down to 0.43. So all in all, these drugs work well, and they do work with durable benefit through that. This, I think, is going to be one of the most important slides I have the chance to share with you this evening, because there's a lot of discussion about, okay, so they all work well. Why would I put them on this lorlatinib drug that has worse side effects? I've heard about all these CNS toxicities. It's hard to manage all this. Well, if we're going to say we trust the data, let's look at the data. This is a comparison of the frontline versus crizotinib, those 4 studies we just talked about. The treatment-related adverse events leading to dose reduction. Let's start with the CROWN study. 49% of patients on lorlatinib had to be dose adjusted. That's not insignificant. That means there were toxicities associated with it. Crizotinib was 47% though. So that suggests it also needs a lot of tweaking on our end. Then we go to the other 3 studies. Alectinib versus crizotinib were 16 versus only 21 for criz. Brigatinib versus criz were 28 versus 29. And ensartinib versus criz was 24 versus 20. So all the drugs had to be adjusted similarly to the crizotinib control arm, and lorlatinib seems to be higher. And I don't have a great explanation for that other than to say it's cross-trial. But this is the important point that you really need to hear. The treatment-related adverse events leading to drug discontinuation. Only 7% of patients had to come off of lorlatinib because they couldn't tolerate it after appropriate management by the physician. The crizotinib arm was 9%. Let's look at those other 3 studies. Alectinib was 11, brigatinib 12, and ensartinib 9. So accounting for cross-trial comparison as best we're able, what we can say is it does not seem that more patients have to come off of lorlatinib than the other 3, or the 3 second-generation drugs, if we manage it properly. So yes, there are newer side effects, and I'm hopefully going to share some of those with you and talk to you and make you comfortable with managing them. But if we do manage them well, the patients are able to stay on this drug and get some good benefit out of it. So how do I think about this? We've talked about the basic science. What's the most potent ALK inhibitor out there? Now I have to think about the clinical scenario, right? Because 30 to 40% of patients with ALK-positive lung cancer will present with brain metastases. That means that 60 to 70 don't. But of those 60 to 70% who don't, they will progress in the brain, most of them at 1 year. We also look at that toxicity profile. So if we're trying to parse out where do patients fail and how do they do? Again, from Ignatius, we have this, this is the hazard ratio in all patients. There's that 0.28 for lorlatinib and all the about 0.5 for the other drugs. If we look at patients without brain metastases, you see those numbers come a little bit closer for alectinib and for ensartinib, 0.4 versus 0.32. So those are a little bit closer if there aren't brain metastases. But again, this patient population is prone to presenting with and then developing brain metastases. So we need to consider what the progression-free survival is for those patients. And the hazard ratio for lorlatinib in patients with brain mets drops to 0.2% for progression-free survival. There we start to see the alectinib space out a little bit more. So that's really what is driving the benefit of lorlatinib is progression-free survival in the brain. And when we look at that on the CROWN study, the 12-month cumulative incidence was 2.8% versus the control arm of crizotinib at 33%. So we dropped that by 1 log fold by putting them on a newer drug. So clearly lorlatinib works well in the brain. How do we look at that in the first line? This was patient SG, a 58-year-old presented with a cough just over a year ago and was found to have a 3-centimeter right lower lobe lesion. They went for a curative intent resection, but due to positive level 7 and 8 nodes, it was aborted and he was diagnosed with stage 3 non-small cell lung cancer. This patient was ALK positive on both liquid and solid tissue testing. There was a decision made to treat for cure with carbotaxol and radiation. This was done September of last year through November of last year. So this patient wrapped up right about a year ago. Unfortunately, their restaging scans just 2 months later did demonstrate 2 CNS lesions, the most prominent one seen here. So what do we do with that patient? Well, 5 years ago, they probably gotten stereotactic radiosurgery. In this case, the patient was put on lorlatinib December 8th, 2020. They had good tolerance with no CNS side effects. But what you see are graphs of their cholesterol and triglyceride levels ranging from about 250 up to just over 300, and then about 140 up to just under 300. So these are the most common side effects we see with lorlatinib, are those elevations of the lipids. The patient had scans done 2 months later, and what we saw was an intracranial complete response with resolution of both CNS lesions. You can see the illustrated one here. So it does work well in the brain, and I think can spare our patients some of the toxicities that can occur with CNS radiation, even stereotactic radiation. But it is a newer drug. It does have different side effects. I mentioned that the hypercholesterolemia and hypertriglyceridemia were the most common side effects that we saw, and indeed they were, with 82 and 61% of patients developing those. Edema was actually the most common cause for dose delay and dose reduction. We also saw some peripheral neuropathy at 44%. And then you start to get into those cognitive effects, the CNS side effects that we worry about. In general, the way we manage these side effects, if they are mild, you can continue to try and dose through that, or you can hold it, see if it resolves, and then reattempt the same drug or same dose level, or you can dose reduce it by 25 milligrams. I should point out that the starting dose for lorlatinib is 100 milligrams once a day. First dose reduction is down to 75 milligrams once a day, and the second is down to 50 milligrams once a day. If they can't tolerate 50 milligrams once a day, they should probably be discontinued from the drug. If patients are to develop grade 2 or 3, which are moderate or severe toxicities, the drug should be withheld. They should be allowed to resolve to grade 1 or better, and then reinstituted at 1 dose level lower. If they suffer a grade 4 side effect, they should be discontinued from lorlatinib. Now, what we've talked about so far has been the phase 3 first line data. What we're going to talk about now is the phase 2-3 data in second, third, and fourth line use of lorlatinib that got its preliminary approval in patients who have failed prior ALK inhibitors. So in this more heavily pretreated group of populations, we only saw dose reductions in 22%. Remember, it was 47% or 49% rather in that first line population, and dose reductions in 20% of the patients. Again, that most common cause was edema. The incidence of permanent discontinuation was low, only 2% of patients. So that's 6 out of 117 patients. Remember, in that first line data, it was 7%. So in this more heavily pretreated population who are maybe more accustomed to dealing with side effects, patients seem to tolerate the drug better. Now, Ignatius did a good job here of lining up these side effects and showing when they start. I have fortunately not had the challenge of seeing any acute psychotic side effects, but we do see some of those on lorlatinib. They have been reported, and those occur quickly, usually in the first couple of weeks. We do start to see, though, over the first and second month, increased appetite, slowing of speech, and those lipid elevations start to rise. This is very busy. Please don't try and read it. I put this slide here because I want to speak to you about one of the most important things in managing patients on lorlatinib, and that's involving the caregivers for these patients and helping you take care of that patient. Look, we only get to spend maybe 10 or 15, maybe 20 minutes if we're lucky with our patients on these types of drugs every month. And that's good for the patient. They don't have to hang out with me. But I also am going to struggle to pick up on subtle changes in maybe their cognitive function, maybe their mood or depression. So when I start patients on lorlatinib, I ensure that they and their loved ones know that these can be significant side effects. And the sooner they can share with me that, Uncle Bill, he's not as excited to go have breakfast with his friends anymore. He wants to sleep more. He just seems more flat. Well, I might recognize that as some lorlatinib associated depression and consider instituting a SSRI or consider lowering the dose. So it's really important that you involve the family members in this. What do those CNS side effects look like? Well, we saw these in 40% of our patients, most commonly cognitive function, mood changes, and speech pattern changes. And that speech pattern change I describe as it's like putting an old 45 LP on and playing it on a slow speed. It's just a slow, drawn out speech pattern. 12% of patients did see more than one type of CNS toxicity. I will point out, though, remember, this was a pre-treated group, and 72% of these patients, 84 of 117, did have brain metastases present upon entry into the study, either treated or asymptomatic and untreated. Some of these patients had had brain radiotherapy significantly before. In fact, I have a patient now who has been on lorlatinib for 7.5 years, and he had whole brain radiotherapy prior to that. So that's the only person I've ever met who's had whole brain radiotherapy that long ago. And so how do you parse out what those long-term side effects look like versus what the drug is doing? There were a total of 24 patients who required at least one dose modification due to CNS side effects. In 15 of those 24 did experience resolution, with median time to resolution of 12.5 days. Here's the pattern of those in the Venn diagram, where we see that only 6 of the 117 patients had all three. Most of them had the cognition. The second runner-up was mood, and the combination of those two at 16.2% was also fairly common. How do we manage these? Well, if they're mild, I tend to treat through it. If the patient is distraught or distressed by it, I hold it and then continue re-challenging at that same level or reducing by 1. Certainly for any sort of psychotic break or significant depression or cognition issues, I hold it, let it resolve, and then reinstitute at 1 dose level lower. If it's a grade 4 side effect, that's when I do have a very, very strong discussion with the patient about discontinuing it completely. This is what reassures me. You know, with some of the TKIs, they're approved at 1 level, and a lot of us will start them at a lower level and dose escalate as tolerance occurs. This is why I don't feel like we need to do that with lorlatinib. This was, again, data from the CROWN study that Ben Solomon presented at ESMO this year. What happens to those CNS side effects when we manage them appropriately? Well, out of that data set, we reported 86 total CNS events. 48, or over half of those, did resolve. Now, it's notable that 28, or 33%, resolved without intervention. What were those interventions? Well, it was varied, right? You could start a con med, you could hold lorlatinib, you could hold and reduce lorlatinib, whichever it was. We were able to see resolution of those side effects in most of the patients on the phase 3 study, the CROWN study. So that does give me confidence that even if they develop them through appropriate management and dose reduction, they do resolve. Now, what about the hyperlipidemia? I would encourage you to think about the hyperlipidemia just like you think about the hypothyroidism when you're treating patients on immune checkpoint inhibitors. I expect and tell my patients on lorlatinib that I'm going to check their cholesterol before we start, 2 weeks after dosing, 4 weeks after dosing, and then every month thereafter, and to expect that I will have to start them on a statin. The average time to onset was just over 2 weeks at 15 days. And again, we saw these in 83 and 61% of patients, mostly grade 1 or 2. And the grade 3 or 4 were those patients who didn't want to start a statin and thought they could manage it through diet and exercise. Unfortunately, that's not the case, and all of them will need a statin at some point. These were not common reasons for dose delay or dose reduction, and no permanent discontinuations happened due to hypercholesterolemia or hypertriglyceridemia. How do we manage it? I simply start a statin, and it comes down. Which statin you start, though, is very important due to interactions with CYP450. Pitavastatin, pravastatin, or rosuvastatin should be initially considered due to that low interaction. We've had reports of patients who are started on older generation statins that did have interaction with CYP450, and they had severe side effects. Depression was the one that was reported while on lorlatinib. When we switched them to a different statin, maintaining the dose of lorlatinib at the same dose, the depression went away. So this is a really important point to keep in mind. 2 more recently described events. This has come out of the EU data, where we saw hypertension develop 13% all grade and hyperglycemia 9.2% all grade. This is the exact same management. You first institute medical management. If you can't keep it below a grade 3 or 4, hold and resume at the same dose or dose reduce. If you've got maximal medical management for hypertension and maximal medical management for hyperglycemia, and you still can't keep them below grade or a grade 1 or 2, then that's the time to talk about stopping lorlatinib. That's a whirlwind tour. I hope you were able to take something from it. I appreciate your time and attention. Look forward to the next case and the discussion to follow.
Parabéns, Dr. Bauer.
Well, congratulations, Dr. Bauer. It was a wonderful presentation, very clear, very didactic, and you brought us all the data, and we have incorporated the indication in the first line for the patients and already bringing the updated data specifically in regards to the conduction of toxicity of the medications. And really, it's a big limiting factor because the patients are going to take those medications for a long time. Well, nothing that the oncologists, we know, and we just have to have that aspect, the specific aspect of we have to be aware of the peculiar characteristics of each of these inhibitors, the idiosyncrasies that we are managing. And of course, they have different profiles in and on themselves. And now we're going to continue with the case of Elisa Sanfelice. Dr. Elisa is a dear colleague of ours from Curitiba. She is now working in the HC hospital, and she will talk to us about a case, talking about the conduction of her case with a patient with the ALK positive, so we can discuss a little bit more about this. Elise, the floor is yours. Hello, everyone. Good evening. I thank you very much for the invitation of Pfizer and your presence here. Now, I thank, Dr. Todd Bauer mainly for sharing your time with us as well. Now, I'm going to start sharing my screen. Can you see my screen, Dr. Evanios, Dr. Bauer? Yeah, I can see it. Is it small? It's really small. You can share.
Agora sim.
Now we can see it. Good. Good.
Looks great.
Okay, let's do the clinical case. Conflicts of interest, disclosures. So you can read the case, very recent. The first visit of the patient to the clinic was on August 20th this year. Male, 28 years old, recently married. He got married in April of this year, and he's a rep. He works with sales. And he came because he had a pain in the arm for some time. We did an image and we diagnosed a fracture, pathological fracture. And then he had, the left pain for a month in the shoulder, and the imaging really confirmed that it was a fracture in the proximal humerus. And he had talked to the orthopedic surgeon, no procedure, but he was submitted to the oncologist to, investigate. This is a patient that the previous history just had the history of correction of intracranial communication at 5 years old. And this is a patient that had no more comorbidities. He doesn't use any medication. The patient that never smoked, doesn't smoke cigarettes, and was very active, plays soccer twice weekly. But he was less active because, of his pain in the shoulder. Family history, just a granddad with the history of prostate cancer. In regards to the complaint, so he was saying that there was a pain in the left shoulder and the back. He also had a weight loss of about 10 kilograms in the last 10 months. But he was a patient that was overweight and that was trying to lose weight. But over the next few months, he had a very significant drop of weight, and he was complaining about a dry cough. 45 days. So we have the image here in this first appointment, more related to the pains of the bones. So he had an MRI, and this was done in July of this year, and it really showed a lesion in the humerus, or in the head of the humerus, with signs of pathological fracture, and an MRI lumbosacral, and it showed, T2, T12, L2, L4, S1 vertebrae lesions, and even with the compression of the nerve involvement at S1, but no signs of spinal compression. I apologize, I don't have the image of those MRIs here. But besides that, he has some investigation exams here at these appointments. This is a CAT scan from thorax that really show a pulmonary lesion, a mass of 4.4 centimeters associated to adjacent atelectic bands. And we had thickening peribronchovascular of, we had lymphangitis, carcinomatosis, and he had bilateral pulmonary nodules, and he also had he had mediastinal lymph, well, he had the big enlarged lymph nodes. And basically, this is the image that he had in the investigation. You can see the pulmonary mass, very large, and with signs of carcinomatosis lymphangitis. Anyway, he was submitted to the bronchoscopy. It showed that there was a lesion, infiltrating lesion actually, of the bronchus in the lower lobe, right side. And you can see, well, the main hypothesis is, lung cancer. We did the whole staging with MRI. At the MRI, he had a single lesion that by the image was considered undetermined. That's why there is a change in the signal. That's the report, but no capture of the contrast. So it's an undetermined lesion of 0.5 centimeters, and the PET-CT showing that there was a high volume of disease, showing the pulmonary mass, the involvement of lymph nodes in the mediastinal region. We have carcinomatosis lesion, and we even show a capture in the spleen and multiple bone lesions. So you can see here the PET of the patient showing the pulmonary mass and the diffuse capture all throughout the lung, lymphangitis being justified, and he had the compromise of the lymph nodes by the PET in the mediastinal and the cervical ones, and multiple lesions of the bone that we can see here by the PET of the patient. This is a patient that was very symptomatic in this first appointment and with a lot of bone pain using opioids and with low control of bone pain. He was submitted to the transbronchial biopsy that we did on the 23rd of August, and this biopsy shown, therefore, adenocarcinoma poorly differentiated with the cells in the signet ring. And immunohistochemistry TTF1 positive. We also did a liquid biopsy, as you can see, liquid biopsy that we have available here in Brazil, just for the analysis of EGFR, and we can get it through the pharmaceutical industry to do the sampling. And the result is we get the results before the tissue biopsy, but it was an EGFR that was negative. The main hypothesis was ALK positive because of the age, male, and the presence of the signet ring cells. Now, in this period, we had a worsening of the bone pain. The case was discussed with the orthopedic surgeon. There was no indication to do a fixation of the lesion of the humerus, surgical at least, and then we did a radiotherapy antialgic of the lesion of the humerus that caused a lot of pain, and also the one on the back, lumbosacral, and we did that while we were waiting for the molecular analysis of the biopsy. However, the patient evolved to the worsening of the cough and dyspnea in this period, and we didn't have time to wait for the report of the molecular analysis, and we opted to start chemotherapy, carboplatin, pemetrexed, on September 8th, 2021. So his biopsy was on the 23rd of August, 2 weeks about is we have the 7th of September, which is the Independence Day here in Brazil. So it's a long weekend, and that delayed the molecular analysis. So we ended up having to start the chemo to control the symptoms due to the lymphangitis. And some days later, on the September 13th, we got the report. And you can see immunohistochemistry showing that there is an ALK positive through immunohistochemistry. Now I wanted to get the opinion actually of Dr. Bauer and Dr. Evanios in regards to the therapeutic decision, for this patient, 28 young patient, very symptomatic, but he didn't have any health issues before. He wasn't taking any medication. He doesn't like medication, but he was very symptomatic. Patient that has a lymphangitis with cough, lymphangitis that is symptomatic as well. And on the other hand, this is a patient that had an overweight, and he had a degree 1 obesity before diagnosis, but due to the disease, you can read on the slide, he lost 20 kilograms. So he had lost 10 kilograms on the first appointment, but in that interval of the last few weeks before we started the treatment, he actually lost another 10 kilograms. He lost it very quickly, that weight. This is a patient that was very symptomatic. So I wanted to hear from you, what is your opinion, Dr. Evanios, and mainly from Dr. Todd Bauer, in regards to the therapeutic decision for this patient.
Dr. Todd.
Dr. Todd, the floor is yours.
Thank you. First, what a difficult case. This is the hard part of ALK positive lung cancer is we end up seeing patients who are out there living their lives, and he shows up with a pathologic fracture. And the phrase that we might use in Nashville, Tennessee, where I practice, which is kind of in the southern, a little bit more rural, is he's all ate up with cancer. This guy has cancer everywhere, right? So how are we best able to treat that? This is where I think we have to go to that question of what is our best drug? This guy's 28, he's working, and now he can't. Do I want to give a drug that I know to be good? Like alectinib is a great drug, but is it the best drug? And I would have to say, I would put this guy on lorlatinib up front and watch him closely. If you look at some of the time to response data for all of these TKIs, patients do respond well and they respond quickly. So I'd feel very comfortable managing him with analgesics and starting him on lorlatinib up front to try and control this disease. Even more effective than trying to start them on chemo, as you might think about to try to cytoreduce them a little bit. So upfront, third generation ALK TKI would be my choice. Hey, I was right.
Perfeito. Acho que eu não faria
Perfect.
diferente.
I wouldn't do it different, Elise. I completely agree with all of you. The patients had, losing performance and losing weight. When we're talking about very symptomatic patient, he was losing performance at a very quick pace. I wouldn't wait, and I think that I would start chemotherapy. Yep. Regardless of the situation, even understanding that he had a high proportion, a very high chance of being ALK positive, but we wouldn't be able to start this medication before here in Brazil. So he started the chemotherapy and he used pemetrexed in this case, and probably we have the data that this patient is ALK with pemetrexed maybe is the preference for the subgroup of patient, while the taxane has very poor responses in these patients. So it was the best therapeutic option, but now with the data in hand from the patient that is ALK positive, of course, I agree with Dr. Bauer, I would openly start the lorlatinib, waiting logically for a response that is quicker, understanding that these patients that TKIs, they have a response, and we know that since the time of EGFR and since the time of EGFR, that the responses are very quick. And lymphangitis is impressive. I mean, the patient has cough, and in less than a week, that cough has dissipated in these patients. So I also wouldn't think twice, and I wouldn't change these therapeutic.
Yeah, you bring up a good point. And I want to touch on that real quick. That's when do I have to start treatment? And this kid who, and I can't believe I'm calling a 28-year-old a kid, but in this kid who has this very symptomatic lung cancer, yes, I would start chemotherapy up front just to try and reduce him until you get that back. But in general, if a patient presents with a lung lesion or multiple lung lesions and they're mostly asymptomatic, I do think it's worthwhile holding on starting treatment until we get the results of molecular profiling back. And I don't just mean ALK testing here. I mean broad-based molecular profiling, if available, to try and look for EGFR, ALK, ROS, RET, MET, HER2, BRAF, all these things we have to look for, because we know that they're going to have better treatment options. And unfortunately, in a metastatic lung cancer patient, waiting a week or two is not going to change their outcome, right? So if we wait a week or two, they're asymptomatic, it's okay to talk ourselves primarily off the ledge and talk the patients down and remind them that it's better to wait to treat with the best drug than just treating with a drug because we're anxious. So in this case, absolutely, I would have pulled the trigger on chemo. But as soon as this came back, I would stop the chemo and go to a better drug for that patient. So I think this is a great case for discussion.
Dr. Todd,
Dr. Todd, sorry, let me ask you a question then. Well, we have a problem here in Brazil that, the liquid biopsy is not totally available for us because, for these complete evaluations, and most of our cases, they're managed from a tissue biopsy. So, from the point that we have the tissue, we end up submitting those patients for the evaluation. And here in Brazil, the exception, to the exception of a few programs that sometimes are reasonably slow in making the response quickly, many times we have to dissociate all this material for PCR. We have to do NGS, immunohistochemistry, and so on and so forth. So what is your strategy? What is the best strategy that you use in the United States? I mean, is to go directly to NGS, next generation sequencing. What do you have available to try and accelerate the lab process?
Yeah, I think we're fortunate in the United States, and I fully understand that. I love where I practice medicine because I have access to the latest, greatest, and it's super fun for my patients who would obviously all rather not have to be my patient. But we can send NGS off on our patients up front. And I tell all of my colleagues who do less of the precision medicine than I do, look, they're like, how do you remember all of these different things you have to test for? And I can't keep that in my brain, but I know that I can order NGS and I know that I can get back all those, right? So let's look at a different target. Let's talk about track fusions, right? Track fusions are so rare that you will never find a track fusion if you're just looking for track fusions. You're going to find it on NGS, right? So the idea that we might have to wait a week or two more to get the testing back to test for all of these things is a reasonable price to pay. And actually, if you look at it from a dollar standpoint, if you sequence these, let's say, so EGFR is the most common, right? So you test EGFR, it's negative. You test ALK, it's negative. You test ROS, it's negative. You test MET, it's negative, and so on and so forth. If you can actually remember all those, which credit to you if you can, I can't, you're going to spend more money doing those individual tests than you will doing NGS, at least here in the States. So that is my go-to and what I think the vast majority of people do in the United States.
Obrigado, Dr. Bauer. Elise.
Thank you, Dr. Bauer. Sorry to have interrupted you, Dr. Sanfelice. No problem. So just to comment on the case, really, we ended up opting chemotherapy because the patient was extremely symptomatic, and I tried to withhold it with radiotherapy, just see if I could get the results, but no, we didn't have it in time, so we started with the chemo. And remember, also, it's important to remember that if we don't have the entire molecular profile of the patient, so we don't associate immunotherapy in this first cycle, otherwise we can increase the toxicity. of a TKI in sequence. So if we don't have the entire molecular profile, we always start chemo isolated, and then thereafter, if needed, if everything is negative, then you associate with immunotherapy from the second cycle onwards. So getting the results.
Dr.
of
Sanfelice, may I
a-
interrupt there real quick? Sorry to interrupt. I just want to comment on
Lógico.
that because I really like that decision model of give chemo first cycle and then wait and see if this comes back and then add immunotherapy in. And the rationale for that is because we know that there can be a slight increased risk in pneumonitis with the TKIs
Mhm.
if they have been treated with an immunotherapy up front. In the States, we have seen this trend towards, hey, you know, whether it be carbo-pem-pem or just chemo IO up front for everybody, because that's easy, we can get it going quickly. That's not the right answer. The right answer, as you said, is a measured answer to start chemo. If it's negative, then go ahead and give the IO with it. But we don't want to give everybody IO up front because it can have problems if they are molecularly driven. Sorry to interrupt.
Obrigada, doutor.
Thank you,
Então,
Dr. Bauer. So in sequence, we have the result of the test and the therapeutic options here. We have a very young patient that didn't like to feel sick. He didn't like to take a lot of pills in the day. So right there, we ended up removing alectinib out of the game because he would have to take, 8 pills a day. He had the issue of lymphangitis with a lot of cough. So brigatinib really, there is the higher risk of pneumonitis. I don't know if lymphangitis could bring a higher risk maybe than and then a pneumonitis in the sequence. Also, he wouldn't tolerate a pneumonitis on top of the lymphangitis. So brigatinib was not an option, and we ended up opting for lorlatinib that has an excellent rate of response or quick ORR. The patient needed that at the time. So there was a delay of the healthcare plan, the health insurance, basically, to actually, in fact, get the medication provided. But luckily, we had done the chemo cycle that withhold the disease a little bit, and then he started the drug on October 4th. And on 14th of October, 10 days thereafter of the inception of the medication, he had an improvement in the pain, and he had stopped with the opioid. He was just using common analgesia if necessary, and he had a gain of a weight of 3 kilograms in 10 days. In the lab works, you can see the alkaline phosphatase showing the response in the bone. There was a drop of the ALK. Anyway, so when he visited last week, when he completed a month of use of the medication, he had 0, the scale of pain, no more pain. He had stopped completely with the use of opioids. He had gained 5 kilograms in this first month. And in regards to the lab profile of the patient, the total cholesterol had an increase. He didn't have a good cholesterol previous, baseline, but he had an increase of cholesterol and triglycerides. For dyslipidemia, degree 2, an increase, a degree 2 of cholesterol, and a drop in the tumoral biomarkers in the first month of use. And we still do not have the control of an image, but he wants to play soccer again. And I said, nope, you're not doing that. You have a bone lesion, but he is feeling, super fine. And he didn't have any cognitive changes. And I had thought maybe already starting a statin and he requested, he said, no, look, I'm on vacation. Last week I traveled, and he wasn't really looking at the diet, even with all he was feeling very, very hungry. So he was just eating whatever he wanted, but now he's going to try and, control a little bit of his appetite. But I wanted to actually get the opinion of Dr. Todd Bauer. If in this first evaluation, would we start the statin now with this patient, or would you give him more time to see if he's going to be able to control it with a diet and exercise? I imagine that no, but I wanted to wait a little bit more to start the statin. Dr. Bauer?
Yeah, no, I love your faith in our patients, and I don't question his earnestness in wanting to control it with diet. I actually had he was an ophthalmologist. He was a retina surgeon from 5 to 6 hours away from Nashville who came to see me. Super healthy guy, very fit. And his cholesterol went from about 150 to about 220 to about 300. And he's like, I'm just going to exercise. I'm not taking another pill. Finally, when his cholesterol got to about 560 or 600, he allowed me to start a statin. And in a few weeks, it came back down. So yes, I think he probably does need to start a statin. Unfortunately, it'll come back. And again, a cholesterol of 400 or 500 when he comes back in a month is not going to kill him immediately. So that's okay. But he will end up needing to be on a statin. You know, one thing about the weight gain, something we all struggle with in our patients, right, is weight loss in a metastatic cancer patient who's struggling to take in food and all this. I had a husband and wife. She was the patient. She was coming over. They flew in for visits 2 states away. And he kept talking about her weight gain. And I'm like, no, sir, don't worry about her weight gain. Like, we worry about weight loss. And unless you're telling me she's eating 5 Snickers bars a day, 5 candy bars a day, I'm okay with it. And they both kind of stopped and looked at each other and then looked back at me. And I was like, you aren't eating 5 Snickers bars a day, are you? And she said, I just had my second Snickers bar of the day, and it was about 10 in the morning. So that to say, the weight gain that can come along with lorlatinib can be associated with edema. It can also be associated with what we think is probably an interaction with a TRK receptor in the brain that increases appetite and does increase caloric intake and can just be a simple caloric weight gain that we see. So good for him for gaining five kilogram, but let's watch that closely going forward. And he's going to end up on a statin, I think.
Uma dúvida em relação ao ganho de
One
peso.
question about the gain of weight for men is not so much of an issue, but really for women, sometimes, you know, it can be an issue. Dr. Bauer, do you think that, do you have any treatment for anxiety as well to try and decrease a little bit of that appetite? Or is it just, you know, trying to close the mouth and, you know, doing the diet?
So first, some of us guys are proud of our schoolgirl figures. Okay. So let's not say that guys aren't worried about the weight. But second, no, there's no clear diet we can recommend. It's just being aware of it and counseling them that they're going to have to be cautious of that with this drug.
Lógico, se for por edema,
And if it's by edema, we treat edema. Elise, it was a very sexist comment on your side. Come on, we worry about our figure.
Thank you.
I didn't like it. But anyway, well, I wanted to say that women are more aware. We are more, you know.
In the United States, that'd be a lawsuit right now. I'm just telling you.
Provavelmente.
Well, probably, yes. So let's change the conversation. So, Elise, your case is done? Okay.
Great case. Thank you very much.
Então tá. Então, Dr. Bauer, eu tenho
So,
duas.
Dr. Bauer, I have 2 questions for you, and I want to, well, while I'm waiting for the questions from the audience as well. So, about the cases per se. So, actually, most of our patients, ALK patients that we have, they are patients that are really taking other medications, well controlled. And well, we are going to discuss actually for this patient second line. I mean, this is a mutation that is rare. It's a rare alteration. It's a rare mutation to see in the patients. So in fact, we do not see that every day in the practice, in the clinical practice. So most of our patients are taking another medication and they're waiting, you know, a progression to be treated. And then there is my question for you in that scenario that I just described. And some of these patients, they were treated with radiotherapy. Well, today, most of the radiotherapy is radiosurgery, is not total cranium radium. But do you see radiotherapy as a factor, as a risk factor for the complications, neurologic complications in these patients that with lorlatinib? And then the second question connected to that is, have you done with these patients that progress with the medications anti-ALK, first or second line, do you have the custom of doing an analysis with such as EGFR? Do you also look for a mutation, ALK mutation in these patients, understanding that eventually that superimposition of the ALK mutation with the rearrangement of ALK is a factor that would increase the response to lorlatinib to select among the situation between lorlatinib, or it doesn't make any sense and you go directly to a medication, whether if it's second line or eventually, logically, lorlatinib once and for all. Sorry for the long question.
Long question. I feel like there were 7 questions in there. I'll do my best to try and answer each of them. They're all very pertinent though. So let's talk about this. If I have a patient who, and I think I understood this question correctly, if I have a patient who is on a chemotherapeutic and then I find an ALK fusion, do I stop the chemo and switch them to an ALK inhibitor, or do I continue the chemo until progression or toxicity? In that case, I will stop whatever they're on and put them on an ALK inhibitor. I think that's appropriate transition. There's a question about, I believe, what if they're on an ALK inhibitor and they progress? So let's say we have a patient on alectinib. Do I inherently resequence that patient to look and see what resistance mutations they have? I do not. Unfortunately, that's not the practice right now. I'd love it to be. And I think it will get there at some point, just like looking at the ALK variants will get there at some point. If you look at the data, and it was an Alice Shaw publication that came out from our Crown group about, or it was actually the phase 2/3 data, patients who'd been treated previously, if you can identify a resistance mutation versus those patients who progressed and they just had the wild type EML4 ALK fusion, the response rate to lorlatinib was significantly different, suggesting that there was a bypass track that had occurred that was not responsible for failure of that current ALK inhibitor. With that being said, and this is again that the scientific purity says, let's test everyone, find the resistance mutation and act on that. The clinical reality is, as I call it in my mind, is if someone's on alectinib and they progress, the best shot I have to treat that patient is lorlatinib. So I'm going to flip them to it. In worst case scenario, 2 months later, they have not responded, and then I flip them to chemo. That's sort of my thought process along it. Though, one caveat to that. If I have a patient who is on an ALK inhibitor or any of these other targeted therapies, and I see that they have an oligoprogressive disease, let's say you have one new lesion in the liver or one new adrenal lesion. I think when I trained, we would have stopped whatever we were doing wholesale and shift and start a new treatment. As we better understand tumor heterogeneity, I think there's a lot to be said to, all right, you've got a new adrenal lesion, let's radiate that using SBRT. And then let's continue the therapy that's working on 98% of the rest of the disease and extend the benefit of that therapy out, and only shift therapies when we're forced to do so because we can no longer treat 1 or 2 spots.
Perfect. Perfect. Thank you very much for the answer. And I realize that you also do not use eventually the brain metastasis to select the lorlatinib or eventually other medication. So you go directly, you prefer to go to the 3rd generation medication, lorlatinib. Okay, so here's a question that maybe is conceptual because I don't know if you had that option before. A patient that progresses to lorlatinib, so the patient that progresses to the 3rd generation drug, the idea is still to do the reanalysis of this patient, or do you continue directly to, for example, for Empower 150 and this patient for chemotherapy, or for, understanding that this is obviously not an oligoprogression, which would be the systemic progression, and that would we would need a therapeutic change?
Yeah, so if there's systemic progression and we need a change and they're on a 2nd generation ALK inhibitor, I will likely shift them immediately to lorlatinib. If they are on lorlatinib and they progress and they've already been on a second generation ALK inhibitor, that's a scenario that scares me at this point, because I don't have a good answer for you about what to do. In that situation, honestly, I would probably try and continue the lorlatinib so we don't see a tumor flare when we hold it, right? And then I would sequence it. Maybe we find a CMET or some other bypass tract. And this is way off the reservation. This is definitely not FDA approval. This is not Pfizer labeling. They might want to kick me off the call for saying this. Do we think about adding another targeted agent? We get a little bit creative. This is the beauty of what we do as physicians, right? We meet the patient where they are, we treat them, and we talk with them and say, hey, let's try this thing and see what happens. Insurance doesn't love it when I do that, but sometimes you get a good peer-to-peer reviewer and they let you play a little bit fast and loose.
Perfeito.
Perfect.
Elise, você tem mais alguma pergunta?
Elise, do you have any more questions? Well, I think that you actually asked all the questions that I wanted in regards to sequencing and in metastases in the brain. Well, good, Elise. Well, we are getting to the top of the hour, 9 p.m. local time. So this is our limit. And I would like to thank immensely for Elise for being here. It was a very nice case, very cool, very interactive. And it was a privilege to be here by your side. And I know that, you are a little bit mad with us, with men, because we don't worry about our figure. One, Dr. Bauer, thank you for your wonderful class, an incredible class. And it was very clarifying, and it allowed us to see your experience on this scenario, that you have more experience in the use of lorlatinib, and it was recently approved in Brazil. So we have, we don't have that practice that day to day, but we hope to use that more frequently and to be able to bring better treatments for the patient. Thank you for Pfizer for the privilege to be here with you, to be in this meeting, and thank you all. And see you in the next Lung Connect Cancer so we can discuss more cases. Thank you very much. Thank you for your attention. Have a nice evening and have a wonderful rest of your week. Thank you, Dr. Todd.
Thank you, everyone who joined, and Pfizer for sponsoring, and the team that made it. Well, great case, Elise. Wonderful and great monitoring. Appreciate it.
Obrigada. Eu deixo claro.
Thank you. And I don't hate men. I was